Hello, class. My name is Roger Moore, and today we are going to be talking about Iboga and tinnitus, exploring pathways to successful treatment options. So, an outline of this experiment, we are using Iboga in order to help cure tinnitus. So, Ibogaine users have been reported to experience extended cessation of the auditory impairment tinnitus following oral administration of the plant alkaloid. It's completely unexplored in modern literature, and there are zero journals mentioning the link. Experimentation will be focused on the therapeutic treatment of this auditory disorder using Ibogaine at various strengths of dose and number of doses. This research topic is intrinsically linked to both psychedelics and neuroscience as it explores the application of a psychedelic substance to modulate neural activity and alleviate tinnitus symptoms by targeting the underlying neural mechanism. We aim to provide valuable insights into the complex interplay between psychedelic compounds and the neural substrates of tinnitus, thereby advancing our understanding of the therapeutic action and specific Ibogaine protocols associated with greatest measures of success. A quote that I quite like, Ibogaine is an extremely dirty molecule, a molecule that has high affinity for multiple receptor sites and works on every neurotransmitter system that we presently know about. And by acknowledging Iboga as a treatment option for tinnitus, we can better understand both and design exponentially better drugs moving forward. So a bit of background regarding tinnitus and Iboga. There's currently zero FDA-approved medications specifically for tinnitus. There's off-label uses of several drugs that are out. However, those drugs are oftentimes actually associated with increasing these symptoms or initiating them in the first place. Things like earwax removal, noise suppression, or white noise machines are often recommended. And Iboga is a plant native to Gabon, Cameroon, Congo, Africa. It's Tabernanthe iboga of the Apocynaceae genus. And traditional Iboga plant medicine was taught to coastal Africans by forest-dwelling pygmies. So the ceremonial use of Iboga goes back into prehistory. And it was actually, Ibogaine has already had a stint as a pharmaceutical drug known as lamberine. Ibogaine was isolated from Iboga by Dabowski and Landrin in 1901. And Ibogaine is believed to be a glutamate receptor antagonist via modulation with MDMA. And this research is quite lacking as the studies in this area are all over 20 years old at this point. So, what is that link between tinnitus and Iboga? So, unfortunately, tinnitus research is also very limited, and this 2016 paper is our best indication for using glutamate receptor antagonists in the treatment of tinnitus. So, believe that the excessive release of glutamate between terminal fibers and inner hair cells at the synaptic cleft of the auditory nerve is believed to produce tinnitus. Glutamate is produced excessively in the cochlea when there is damage to inner hair cells from noise exposure, autotoxic drugs, or disease, and this leads to osmotic swelling and cell lysis triggered by excessive entry of calcium into the primary auditory neurons. Drugs like acamprosate, carovine, memantine, and flupertine all have glutamate receptor antagonist qualities and are all indicated for tinnitus. Agonist activity of glutamate is primarily mediated by IGLUR, specifically NMDA and AMPA and mGluR. So, Ibogaine, NMDA, and glutamate. There is, as I said, limited modern research on this topic. However, in the mid 90s, early 2000s, you can see there's a plethora of research discussing this kind of link, whether it's how Iboga has a modulatory effect on addiction. It's shown to competitively inhibit piperidine binding in rat forebrains, blocking glutamate-induced cell death. And Ibogaine practically abolished glutamate uptake by cortical astrocyte cultures. So how do you measure glutamate in humans? This is the study that we're using as a backbone for our measurements. They found testing various measures that S lasers used at a magnetic frequency of 7 Tesla gave the greatest accuracy and was able to discern noise from signal relative to glutamate levels versus glutamine levels in the human brain. So this is achieved by selectively exciting protons in a specific volume of interest while minimizing signal contamination from outside that volume of interest, resulting in better spatial specificity and accuracy. This is particularly important for measuring glutamate, which is present in low concentrations in the brain and can be difficult to distinguish from other metabolites in MRS techniques. And the significance of this, it's believed that tinnitus, although 740 million individuals sounds like a high number, it's believed to be underreported. For anyone suffering from it, it's common knowledge that there are no treatment options, and the drug options have dubious benefits and are oftentimes, you hear of horror stories where they provide the antithesis of a cure. So tinnitus increases with age. It becomes more and more likely that you'll suffer from it as you move on in life if you don't now. There are 0 FDA-approved treatment options for tinnitus. It's been linked to increases in attempted suicide, depression, anxiety, all sorts of health measures that decrease when tinnitus increases. So the word on the street is that there's no medical cure and there will be no medical cure, and symptom abatement is the best that we can do using things like white noise. So, what are we trying to explore here? What is our scientific question? Can the administration of Iboga alkaloid Ibogaine reduce the severity of tinnitus in affected individuals? And will symptom cessation coincide with decreased glutamate levels? Our hypothesis is that Ibogaine will reduce the severity of tinnitus in a dose-dependent manner equal to the decreases in neuronal glutamate measured using the S-laser technique previously discussed. So the goals and the aim of this study, we are to determine if Ibogaine is a favorable treatment option for tinnitus. We are exploring the effectiveness of varying Ibogaine dosages and dosing numbers. And we are going to compare decreases in tinnitus symptoms with achieved glutamate reductions in total Ibogaine consumption. And our goal, again, to uncover improvement opportunities in study design, proceeding efforts towards FDA approval and subsequent clinical trials. Endpoints and outcomes of this study. So our primary endpoint is to achieve a 25% symptom reduction in low-dose Ibogaine groups and 50% symptom reduction in high-dose groups. This is for the tinnitus handicap inventory issued immediately after the dosing event. So groups participate immediately following the end of the dosing event. Groups participating in multiple Ibogaine dosing sessions should experience greater cessation than these numbers mentioned for individual doses. Our secondary endpoint is to match symptom reduction as measured by the tinnitus handicap inventory with reduction in glutamate levels as measured by S-laser at 7T magnetic strength. And exploratory outcomes would to be observe a cumulative effect of symptom cessation regardless of second dosing events occurring outside the presumed length of time Ibogaine will be present in the participant's system. And this is referring to Ibogaine has a half-life in human plasma of 4 to 7 hours, and so the participants going into the 2-dose group will be administered that second dose at the 48-hour mark following the first dosing event, and that coincides with the upper end of that number, 7 hours being the top of the high side of the half-life, coinciding to 48 hours or 49 hours. So we're starting right there when everything should be out of the individual system. If it's the lower end of the spectrum, 4-hour half-life, that coincides to 12 and a half half-lives. And so innovations, everything about this study is innovative. There's no current treatment options for tinnitus. There are no primary drugs for tinnitus, no first-line defenses or first-line treatment options. And there's no indication that that is being sought after whatsoever. Ibogaine is not studied very much in modern history. It's quite expensive to do so given the lengthy duration. And so the results and the effects on glutamate are primarily measured in vitro and in rat studies. All right, so designing our experiment. We have 5 groups for this experiment. Group 1 is a control group, and then groups 2 and 3 are single dosing events. Groups 4 and 5 are double dosing events. So we have decided to use a dosing schedule that is relative to the participant's body weight. This is common in Iboga studies, and it's something we may change in future studies. But we are doing 10 milligrams per kilogram participant body weight and 20 milligrams per kilogram for the low and high doses, respectively. And this coincides with previous studies, kind of maxing out at about the 20 milligram mark and lower doses in the 10 milligram mark. So we already discussed second doses being administered 12 half-lives after Ibogaine later. S laser measures using T7 magnetic field strength will be taken immediately prior to the first administration event, 6 hours after administration, 12 hours, 24 hours, 48 hours. And if you're in groups 4 and 5, this event will repeat itself. So S laser readings will be administered alongside follow-up tinnitus intensity questionnaires that we'll discuss shortly. So the scientific methods for this experiment, eligibility and suitability of participants is a big problem in psychedelic studies, particularly using Schedule 1 drugs that are hard to come by and often sought after. People rely on their questionnaires to gain access to the study. And so we want people that already have an established treatment history with tinnitus. So that might be a limiting factor we can improve on in the future. So participants have to pass an ECG prior to administration. That's to make sure they're heart healthy enough to survive the experience. And they are also monitored using fingerclip heart rate and blood oxygen monitors during their experience. So the effectiveness, participants will complete the THI before the treatment, the day after treatment, and during check-ins at months 1, 2, 4, 6, 9, and 12 months following treatment. And again, that's when S-laser administration will be taken as well. Scores will be plotted and analyzed to determine which protocols are more efficacious than others, and those scores will be plotted alongside S-laser scores as well to measure correlations with decreasing glutamate in auditory neurons. All right, so how do we link glutamate to this? As I was just discussing, the glutamate levels for all participants will be measured using S-laser, referring to the magnetic field strength used to best separate glutamate signal from glutamine noise. That's the 7 Tesla, the strength of the laser used to find glutamate. Tests will be administered at the following points relative to initial dosing. We discussed this as well, and additional readings following the THI are being co-administered, and we believe that these results should mirror one another. We are anticipating glutamate decreases to coincide perfectly with decreases in tinnitus. Whether or not that'll be proven to be true, the future will hold. All right, so expected outcomes is just telling you, although we believe all groups besides control will experience a degree of tinnitus cessation, our high-dose group is anticipated to find greater relief than our low-dose group. Groups partaking in second dosing events are anticipated to have greater cessation relief relative to their single-dose counterparts. This is based on limited subjective reports where one user found complete and extended relief at 19 milligrams per kilogram, and another found more limited and temporary relief at 14 milligrams per kilogram. We believe groups 3 and 4, which receive identical dosages but spread out, will experience cessation most similar to one another. We expect this difference will not be statistically significant, gleaning insight into a cumulative nature of treatment. And remember, groups 3 and 4, that's the high-dose single event and the low-dose double event. And ways we can improve this study, or we can change on it in the future. We could do a crossover design where individuals that are doing the double dosing, they participate in a low dose and then high dose, or vice versa, a high dose and then a low dose. That's to explore any sort of accumulated benefit, which is believed to exist, seen as the cessation extends past the acute effects of the drug. So using Iboga total alkaloid extracts is also an option. So lamberine, the original Ibogaine pharmaceutical drug in France, was actually a total alkaloid extract. And so there's plenty of literature references where mountain climbers would use it to reach the summits, etc. And we could also alter the dosing design. So we dosed people dependent on their body weight, but we could follow a dosing protocol where all individuals, regardless of body weight, receive identical doses. Altering testing schedule to measure glutamate. So using S-laser glutamate measures at time intervals different from those that we have used in this study. So we chose the 0 hours, 6 hours, 12 hours, 24 and 48. They're obviously intervals of one another. And so we were hoping to be able to measure using those intervals most successfully. But in the future, we could alter them. So future directions, where we want to go from here. Upon identifying Iboga plant alkaloids valuable in treating tinnitus, we think we should begin working toward FDA approval to remedy the indication. Single applications of Iboga vary significantly from traditional use, which takes place over 5-day ceremony. So it's understood in traditional ceremony that there is a cumulative benefit, which is very different than single dosing events used in addiction interruption, as it's most commonly understood. Its understood usefulness in Western society. So if multiple applications are discovered to be more efficacious, we should push to distance ourselves from single application treatment styles. And also we would like to push towards sustainability efforts as we find new indications that Ibogaine could treat. It's more and more important to find alternative plant sources, of which there are a couple, but not many. Tabernanthe iboga is certainly the most potent, but synthetic Ibogaine should be preferential to plant extracts. And so FDA approval in the future, we're looking to treat tinnitus to provide relief to millions and possibly millions. A structure-activity relationship analysis may provide insight into creating novel drugs for those contraindicated by heart conditions. So by better understanding the connection between glutamate and tinnitus, we might be able to design better drugs that are more heart healthy. All right, and in summary, again, the Mayo Clinic quote, which is posted on their website today, you can go check it out. Drugs can't cure tinnitus. That's yet in my imagination, in my mind. It seems like they've relegated cures to a land of fantasy, but no longer. So Ibogaine is proving successful in managing the phantom audio symptoms of tinnitus in subjective reports, and so we're trying to document that in a more scientific manner and better understand the correlations with glutamate reductions, as it's believed in supporting studies to play an effect or a primary role even. So further research will be to discover any benefits associated with multiple applications and how those dosing protocols influence results. In order to scale treatment, we need synthetic Ibogaine. Research demonstrates that there's a link between glutamate receptor antagonists and tinnitus treatment, so we would like to verify that, and we would like to verify that Ibogaine is a glutamate receptor antagonist, presumably by lowering glutamate or examining that decreased glutamate level. So I really appreciate all your time you were able to afford me today. Thank you so much for everything you've done this semester. The class has been spectacular. Loved every minute of it, and I hope you enjoyed this presentation as much as I enjoyed putting it together. Thank you so much.